most common toxicities that you will see in private practice, either coming from chemicals or even some of the drugs that we take over the counter on a regular basis. But before we talk about that, did you guys have any questions about yesterday's lecture? Isn't it easy? It's very easy. Yeah, I like the stepwise approach. You guys will not. Someone asked yesterday if you will have 45 questions. There may be 5 or 6. I mean, fair question. That will take you a lot of time, but
I said 10.
Oh, you did. But no, maybe 5 to 6 questions, and just follow along like we did in class yesterday. I think, I thought it's an easy approach. I didn't know about this approach either, so I love it actually. So, any other questions about it? Okay, so let's do a little review. So, first question, what cofactor is involved in the remethylation of homocysteine into methionine? B12, right? B12 is the answer up there? Sure. B12, and what is the substrate that donates the methyl group? Remember, don't get got, I'm not going to say it. 5-methyl tetrahydrofolate, right?
Oh, yeah.
Yeah. So those two are responsible for connecting the methionine pathway with the folate cycle. All right. Questions about that? Second question: what hormone does corticosterone become? One person?
Cortisol.
Close. Thank you for answering. Sterone. Just try to give a little hint. May not see that question, but you may see this. What about question number 3? What enzyme deficiency causes black deposition in connective tissues?
Tyrosine.
Tyrosine? What enzyme? But thank you for answering.
Y'all quiet.
Yeah, no, I appreciate it. Anybody? So, do you guys know the condition? What's the condition for the black deposition pigment? Ochronosis? Sure. No, that's okay. Y'all, I understand. Y'all studying for something else. You'll get it. So, no worries. Enzyme is homogentic oxidase. The condition is alkaptonuria, and the deposition is okay. And what is chenodeoxycholic acid? Biosalts, absolutely. What makes it a bile acid?
Tyrosine.
Conjugated with glycine or taurine, it becomes a bile acid. All right. Thank you. Great job. Any questions?
Isn't it bile acid that when it conjugates becomes bile salt?
Did I say that backwards? Oh my gosh, I'm so sorry.
Oh.
Wow. See, I got down again. Wow. Yes. My apologies, man. I'm not trying to mix you guys up.
I gotta restart my recording now.
It's a bile acid. Chenodeoxycholic acid is a bile acid. Once it's conjugated with taurine or glycine, it's bile salt. My apologies. Scratch that. Disregard. Say it again.
Points back.
Points back. Points back. Well, I have to take that question off the test. I don't even know if it's on the test. So, you guys asked very good questions in class, and I appreciate it because it shows me that I'm getting old and either I don't remember what I was taught or I never knew. But there was a good question about factor 12 yesterday. And basically the take-home message is that they believe that the other factors kind of compensate for its absence. So that's why there's no clotting disease or clotting factor deficiency with factor 12, when factor 12 is deficient. And so that's why most people present with those symptoms. This deficiency is usually found by accident when people are at the hospital getting tested, just regular routine screenings. It's most common in Asian population, and the estimation is 1 per 1 million people, but they don't know because if they don't have any issues or any needs to get any type of blood tests, they probably wouldn't detect it. And so when they do common blood tests like the PT or APTT, the results are similar to that what is seen with the APS syndrome that we talked about in block 1. So they think it might be that, but then after further investigation, they realize it's deficiency of Then something else you guys talked about yesterday or was brought up, which ties in nicely to, there was a paper sent out last night, I know you guys probably haven't looked at it, but talking about how calcium is an important component of trauma care, and so it's believed that it should be added to the lethal triad to become the lethal diamond of care, including hypothermia, acidosis, and coagulation issues. And so that the paper that was sent out last night, I'm not sure if you guys got it yet, but if you did, I know you probably didn't have time to look at it. But you guys will be on the front lines as PAs, probably in this next set of large-scale combat operations that we're gonna have. So what you do and what you find out when you are clinicians and treating patients will be very critical for determining if this diamond theory is effective. So this is gonna be all on you guys. The torch is gonna pass to you. Any questions? All right, so now we're gonna get started with today's lecture. So toxicology. Toxicology, the following toxicology, Paracelsus said toxicology was the study of poisons, but that definition has been extended, and now basically toxicology is the study of hazardous or adverse effects on biological systems. So there's many different fields of toxicology, descriptive, mechanistic, those work together to determine what the mechanism of a toxic agent's or drug's action is. Non-clinical is what I have done in my research, looking at animal models, determining exactly how toxic agents work and what it does to the body, animal models globally. Then we have forensics toxicology, which we know that's medical examiner, that's a mixture of analytical chemistry and toxicology. And what you guys will probably see in your primary care practice is clinical toxicology, which is basically the study or the treatment of poisons or acute toxic exposures. And so when I was in grad school a long time ago, probably before half of you were even in school or born, this paper came out and we had to read it from my toxicology class. And the take-home message from this paper was that even water can be toxic. So they injected water peritoneally in an animal model, and they found that this water caused lesions that were more mild but similar to that of chemical irritants. So this just furthered the concept that almost anything can be toxic, and how we're exposed to it also plays a role in an agent's toxicity. So we've talked about cytochrome P450 enzyme, also called CYP enzymes. bit so far. In this lecture, I wanted to include this is just for your information, but many of the substances that are toxic are metabolized by cytochrome P450 enzymes, in addition to 60% of the drugs that we take and you guys will be prescribing in your practice. So you guys will become very familiar with this. Also, I thought this was interesting, the adrenal steroidogenesis pathway. Most of those enzymes that we talked about are cytochrome P450 enzymes as well, but they are named differently in different parts of the body. So these enzymes are very important. We're going to talk about in the next block how our genetics play a role in the function of these enzymes. Sometimes our genetics make are fast metabolizers, slow metabolizers, or even intermediate metabolizers. So it's not a one-size-fits-all in every case when these enzymes are metabolizing or when drugs are acting on these enzymes. So as clinicians, you will have to, take into account what your patients tell you in order to better figure out the best treatment plan for them. So these are some of the major isoforms of cytochrome P450 enzymes. You don't have to remember all of these, but we're going to talk about two of them today because they are involved in the metabolism of some of the toxic things that we're going to discuss today. In your practice, you are likely to see Tylenol, aspirin, carbon monoxide, and cyanide poisonings. There are other common ones, but these are the most common. So, with Tylenol or acetaminophen, also called N-acetylparaminophenol, APAP is what we call it for short. This is reduces fever and it's a pain reliever. Here are the minimum toxic doses for adults. So for adults, 4 grams per day is the limit of safe dosing. So if we have more than that, then of course we might be susceptible to liver damage. So APAP is metabolized by 2 phases of metabolism. Phase 1, which is that cytochrome 2E1. Phase 2 is glucuronidation and sulfation reactions. Phase 2 predominates as the metabolic means in this pathway, and we're going to discuss that in a couple of slides. But CYP2E1 also metabolizes alcohol or ethanol. So that's why APAP and alcohol are a bad combination. So the treatment for APAP toxicity is N-acetylcysteine. And we're going to talk about why. So in this case study, a 21-year-old, I forgot to mention, so most of these case studies were taken directly from a toxicological book with nothing but case studies. So most of these case studies that we're going to talk about are actually true stories and true events. So in this case, a 21-year-old female was brought to the emergency department by her boyfriend after he learned that she had ingested 30 Tylenol tablets, 325 milligrams per tab, in an attempted suicide. The patient stated that she was not drinking or taking any other medications or illicit drugs. She stated that she vomited, was nauseated, and had a bad stomachache. And her vitals are blood pressure 95/70, pulse 100 beats per minute, respiration 20 beats per minute with a oral temperature of 98.6. So, in doing the math, this 30 tablets that she consumed is almost 10 grams of Tylenol, which, as I mentioned, 4 grams is the maximum safe dose. So she's almost more than double. Now she is more than double the amount. So this could cause significant damage to the liver. Though her vitals are not too alarming, She does have a stomach ache, and that's due to the liver injury because the liver is overtaxed. She was vomiting because, like, consuming any drug could cause vomiting, but when you consume one in excess, of course, that might cause vomiting. Her temperature was fine, and upon physical exam, her ENT, ears, nose, and throat, nothing abnormal there. Her lungs were clear, cardiac function was normal. That moderate mid epigastric tenderness is, of course, due to injury to the liver, and the cranial nerves were intact, meaning that she had no issues with the brain at this point. So, yes.
Well, I guess this one doesn't really give us a timeline. Did she ingest these the same day or is it
Right. There's no timeline. So when you're not given a timeline, you're just gonna go with what you know, and that's gonna be the NAC, which is a great question. We're not gonna always know the exact timeline, but you just stick with the protocols that you know and then adjust accordingly. So, great question. So, the treatment for this patient was 50 grams of charcoal to try to get that absorb that acetaminophen, along with sorbitol. Sorbitol is a laxative, so you're trying to get it out as fast as possible. When you guys suspect or when you know a patient has APAP toxicity, you're going to want to monitor the serum levels of APAP every 4 hours. This patient's level was 215 micrograms per milliliter, which is still significantly high. And so then the first line of treatment would be IV N-acetylcysteine for 20 hours. Now, what was good about this patient is that her AST levels were normal, which is good. AST and ALT, aminotransferase enzymes that we talked about in the last slide, they dictate liver function. ALT is more present in the liver, and so when they are elevated, that is indicative of liver injury. So after they assessed her AST and found it to be normal, this patient was transferred to the psychiatric facility. So how does N-acetylcysteine work? N-acetylcysteine works because it mimics the effect of glutathione. Now, we talked about how in the hexomonophosphate shunt, how we get NADPH as one of the products. So that NADPH reduces glutathione, which enables glutathione to scavenge toxic free radicals and convert it to water so it will be able to be excreted from the body in the urine. So when when cytochrome P452E1 breaks down this APAP, it forms N-acetylparabenzoquinonamine, NAPQ, which is the toxic component. This is highly toxic. Not even that much is metabolized by alcohol, by the enzyme that also metabolizes alcohol, cytochrome P452E1. So what happens is this NAPQ binds with liver proteins and causes free radical formation and hepatonephrosis. So this is that hexomonophosphate pathway shunt that we talked about. Right here is the addition. So what happens is that NADPH that we attain from the pathway reduces glutathione to the reduced glutathione, and the reduced glutathione is then able to scavenge free radicals and form water. The enzyme that catalyzes the reduction of glutathione is glutathione reductase, right? And so here is that HMP pathway, and this is what what NAPKI is doing. So when acetaminophen is metabolized by cyclone P452E1, NAPKI is formed. NAPKI is scavenged by glutathione, and when it does that, it produces a non-toxic substance. But when we run out of glutathione, that's when NAPKI will bind to liver proteins and cause the necrotic hepatocytosis. So we would give NAC, which is acting in a similar manner as glutathione, to interact with NAPKI to make it non-toxic. Yes.
Okay, so the 2-GSH is the reduced form of glutathione,
Yes.
which is our free radical
Scavenger.
scavenger.
Yep.
So when Tylenol is metabolized in the liver, broken down and forms the NAPKI by cytochrome
E2E1.
that gives us the NAPKI. The reduced glutathione interacts with it, scavengers it, moves into excretion, and then so the NCL system basically. So is NAPKI is so toxic, or we need more reduced glutathione because it is so toxic, so it requires a higher
Yes.
glutathione load in order to excrete it.
Yes. Yep. And breaking down that pathway further, which was described by a fellow scholar, here is this pathway broken down. So as I mentioned, APAP is broken down by phase 1, cyclone P452E1, and phase 2, glucuronidation and sulfation reactions. This pathway predominates. 90% of APAP is broken down this way, producing a non-toxic molecule that's excretable in urine. APAP interacts with 2E1, which is after phase 2 gets saturated, so only about 10% form NAPKI. If we don't have NAC or glutathione, that NAPKI will cause hepatocytosis, but when we treat with NAC, that detoxifies the NAPKI, which is excreted in the urine. Correct? Any questions about that?
So you said the phase 2, if you're ingesting the potentially lethal dose, phase 2 is basically overwhelmed. So you have a spillover
Yes.
that hits the phase 1 pathway.
Yes.
Oversaturation of NAPKI, insufficient glutathione in order to scavenge it, that's what leads to hepatotoxicity ultimately.
Correct.
I was just gonna clarify, I think you said, so phase 2 is the normal clearance mechanism.
Yes, phase 2 is the pathway that predominates, and when it gets overwhelmed or saturated, then phase 1 is. Right? Yes.
Is there like a certain threshold that will activate the NAPKI to happen? Or just a little bit amount of it is gonna,
Say that last part again.
like, is there like a certain minimum amount for the NAPKI to get activated?
That's a good question. I don't know the minimum amount that requires NAPKI to be activated, but it's determined based on phase 2 being overwhelmed. So NAPKI may be produced in very small quantities if we consume Tylenol on a regular basis, but if we have glutathione, then it's gonna quickly detoxify. I don't know the exact minimum amount or threshold for the amount of aspirin or acetaminophen required to trigger the phase 2 pathway. Any other questions? Yes.
Sir, for the phase 2, the mechanism, if that's saturated, that would also cause a backup of bilirubin in the body too?
Yes. Yep. So is this clear? Any questions about this pathway? So have you guys ever heard the expression, don't take Tylenol to cure a hangover? Maybe from personal experience, maybe not. So we're gonna talk about why you shouldn't do that, which I've already alluded to. So in this case study, you have a 28-year-old male with G6 PD deficiency, was brought to urgent care after attending a wedding in which he became severely intoxicated at the reception. His best friend stated that he became overly tired from dancing and ingested 8 extra strength Tylenol tablets in order to circumvent the anticipated hangover effects. So this patient was disoriented but able to state that he vomited several times. So his vitals, very similar to what we saw in the last case, except for his pulse rate is more elevated, so is his respiration, and he has a slightly elevated temperature. This patient is experiencing diaphoresis, which is probably maybe due to either the stress from the potential liver injury or even just the alcohol intoxication. And he also experiencing that right upper quadrant tenderness, but all of the other exams were normal. And except for the patient being disoriented, and that could be due to the alcohol as well. So, when you have APAP and alcohol intoxication in combination with G6PD deficiency, basically what's gonna happen, you don't have glutathione or less glutathione, right? So then, and then alcohol induces cytochrome P452E1. So you're gonna have more 2E1 produced. So more 2E1 means that APAP is gonna be broken down by this enzyme to produce a significantly more NAPQ, which of course is very toxic even at a low amounts in the body. So this patient is at significant risk for liver damage, and so how you would treat this patient is you would do the same thing that you did in the last example. You would monitor the patient's APAP levels. You would also give IV NAC and measure their liver function. Now, this was a made-up scenario to make you guys laugh. Nobody laughed, but that's me dancing at my best friend's wedding. In the picture. So that was just like to try to lighten up, but I failed. So I will continue. So, any questions about acetaminophen toxicity?
That was actually you.
Yeah, that's good. In the middle. Right here.
Camcorder. Look at that nice camcorder.
Yeah. All right. Any questions about acetaminophen, how to treat it, and what's going on?
Is that a pinstripe suit?
Yes, it is. That was his choice. That was his choice, and it was a long one too. So. Yes.
Would this patient be at risk if they would have taken the normal over-the-counter dose of Tylenol?
Yes, because yes, because there's still reduced glutathione because he has G6PD deficiency. So it would be less risk than with all these other variables. But yes, that's your question. Yes. Any other questions? Yes.
So if you're treating a patient with a G6PD deficiency, you're in a similar situation, I mean, are you just gonna draw labs more frequently at that point?
So you're gonna have to follow the normal protocols that you do, but that may be something that you consider. You might also have to do blood glucose tests because when liver failure occurs, hypoglycemia might result. You also might want to measure their CBC levels because they might have hemolysis because of the G6PD deficiency as well. So, yes.
So this patient will be fine as long as, like, so just having that thing, as long as they're not taking antitoxins, they're okay, or are they still kind of?
You mean like if they were not consuming alcohol, just regularly taking, so they would probably want to take something else like ibuprofen. Ibuprofen acts on a different system and it's less toxic to the liver. So the metabolic pathway is going to produce less toxic substance than acetaminophen. So ibuprofen is the prostaglandin pathway is involved in ibuprofen. It uses that pathway. So there may be some GI disturbances and liver disturbances by taking ibuprofen, but that is the better line of treatment for somebody with G6PD and for somebody that wants to cure their alcohol toxicity. You should take ibuprofen and of course Gatorade for electrolytes and all that stuff. So, yes.
This is very hypothetical, but if like somebody with G6PD came into the ER and they were drunk and they like hurt themselves, what could we give them?
I mean, you could also give ibuprofen for pain. No, ibuprofen is it's better to use on G6PD because it's not causing the liver damage because it's more disruptive to the GI tract than it is to the liver. So, yeah.
What dance move is that? That's the Tootsie Roll?
No, it's the tick.
The tick?
No, MC Hammer.
Oh,
That's how old I am. Very old. Normally I end it with the splits, but I won't do it. And I did it there and I was in pain. Like 20 years older, so yeah. All right, any more questions? All right, now on to aspirin. So aspirin is another commonly overused agent. Here are the minimum toxic doses based on weight. The enzyme that metabolizes aspirin is cytochrome P452C9. So in this example, we have a 22-year-old female that came to the emergency department complaining about abdominal pain, nausea, and vomiting. She had a history of depression and told the staff that she ingested half a bottle of aspirin about 6 hours ago. So we don't even know how much she ingested. So her vitals are blood pressure 120/60, pulse 110 beats per minute, respiration 30 breaths per minute, and oral temperature 100 degrees Fahrenheit. In terms of her physical exam, ENT was unremarkable, no jugular vein distension, meaning no heart failure. The chest was clear of auscultation and percussion, meaning that nothing was in the lungs and there was no breathing issues. Cardiac exam was unremarkable, valves were normal, but the abdomen was diffusely tender without guarding, and the patient was fully alert and oriented with no cranial abnormality. So that without guarding means that the patient wasn't having any spasms. So we can see I've highlighted the elevated or the vitals that were outside the norm. And so all of these abnormal readings could be due to stress, and aspirin is acetylsalicylic acid, so we know it's an acid. So what is the patient gonna have from our lecture yesterday? Metabolic acidosis. So here are the initial lab reports for this patient. I've highlighted the abnormal results, but the normal lab ranges are on the next page. So urine is normal, but slightly acidic. Specific gravity is normal. Protein, we're seeing some proteinuria, that's a kind of a non-specific result. 2 ketones, this means that the fatty acid metabolic pathway is kicked in, so that's spilled over into the urine. And no red blood cells or white blood cells in the urine is a good sign, and it's indicating that there's no blood in the urine and there's no infection. But the arterial blood gas is showing pH of 7.51, which is what? Alkalosis. What about a CO2 of 11? Alkalosis as well. So this is a complicated, mixed acid-base disturbance that this patient is experiencing, and we'll talk about that as, in order to understand what's going on in this patient. And then her BUN levels are slightly above normal, indicating some stress to the kidneys potentially. But, so, the treatment for this can be complicated because you might see one thing that will switch to something else. So we already know metabolic acidosis, but then this patient is likely also to have respiratory alkalosis. Respiratory alkalosis may be the first thing that occurs because in our body's response, we can exhale CO2 out more rapidly than the other metabolic pathway. And the treatment for this would be activated charcoal with or without sorbitol, and you want to monitor their fluids. Fluid resuscitation is important. And you may need to do hemodialysis in severe cases. So what's causing the metabolic acidosis? This is where the electron transport chain comes into play. Electron transport chain affects the remaining toxicological emergencies that we're going to discuss today. And so what happens is acetylsalicylic acid uncouples complexes 1 through 4 to complex 5. So ATP production is decreased, and when that happens, that's going to cause glycolysis to undergo the anaerobic pathway, which of course will produce significant lactic acid, therefore causing metabolic acidosis. Does that make sense? Yes.
So when you say it causes an uncoupling at complex 5.
So
What exactly?
So the salicylate from acetylsalicylic acid, it basically is taking those hydrogen ions and it's moving them through the membrane here, so we don't get that driving force to produce ATP. So it's just moving the hydrogen across the membrane, and you know how we had to build up that proton gradient, and it's the salicylate is able to interact with hydrogens to move them across the membrane. And so it's uncoupled right here, so you're not gonna have this gradient, so less ATP will be produced.
So you're inducing an anaerobic state.
Correct. So then the body will shift to anaerobic metabolism and lactic acid buildup. Yes.
2 questions. So is the CYP2C9, is that one of the complexes in the electron transport chain, or is that involved in metabolism?
No, that's just the liver enzyme that breaks down the acetylsalicylic acid. But you know that acid is going in the blood and it's going throughout the body. So when it gets to inside the cell, this is what it's actually doing right here.
And then second question, you have weight-based dosing for aspirin, and then there was just a flat dose for Tylenol. Is there a reason?
So I think it is weight-based, but I didn't put that information there. I think, well, let me go back. Yeah, that's what I thought. It's just not on the slide, but I think it is weight-based, and it's the maximum dose, I think irrespective of weight, is 4 grams. Does that make sense?
Yep.
Any other questions? All right, carbon monoxide poisoning. So we see this a lot in the winter months when people barbecue in their garage or spaces that are not properly ventilated. And this is very dangerous because you don't have a carbon monoxide detector. You're not gonna know that it's there because it's odorless and it doesn't irritate our mucous membranes in our system like other gases. Yes.
Sorry, sir.
No.
For the respiratory alkalosis, is it just because you're in pain that they're breathing too fast, or?
Yes. Yeah. It's just you're trying to just get you're in distress, so you're hyperventilating, and that's gonna cause that respiratory outburst. So carbon monoxide, well, hemoglobin has a significantly higher affinity for carbon monoxide than it does for oxygen. And so once we're exposed to that carbon monoxide, it's gonna displace the oxygen. So that too is gonna cause hypoxia in our tissues, because our tissues are not getting oxygen, and it's going to also impact the electron transport chain as well. And what it does is it reversibly binds to the heme A3 copper B center in complex 4 of the electron transport chain, and what that does is that prevents oxygen from binding. We know at that step, water is formed. It prevents the water from forming, so it's going to decrease ATP production, right? So in this scenario, we have a 57-year-old woman with a history of alcoholism and depression, attempted suicide by ingesting alcohol and multiple medications, then lying down in a closed bathroom with burning charcoal. She was found obtunded hours later after missing a therapy appointment. Upon arrival at the hospital, carbon monoxide levels were found to be 31.7%. Serum drug screening was positive for drugs that are antipsychotic, antidepressants, pain, and sleep. Thank you. And sleep. So she was intubated for airway protection and received hyperbaric oxygen therapy, 3 atmospheres for 90 minutes. This is the gold standard treatment for carbon monoxide poisoning. And post-treatment, the carbon monoxide levels significantly dropped to 7.3. This patient, when she was intubated, also had ended up getting some gastric fluid into her lungs. That's why she has the aspiration pneumonia. And so she was transferred to the ICU and given antibiotics for that part of the issue. But obtunded means that the patient is disoriented and there's a potentially loss of consciousness. And so how you would treat this patient is pure oxygen or hyperbaric oxygen therapy. Hyperbaric oxygen therapy works faster at displacing the carbon monoxide from the hemoglobin to return oxygen levels to normal. And how does carbon monoxide work? So again, electron transport chain, complex 4. What this does, it reversibly binds to this interface between heme A3 and copper center, and that prevents the water formation in this step of the electron transport chain. So this too will shift our metabolism to anaerobic metabolism, and of course ATP production will be reduced. Are there any questions? All right. Cyanide. So cyanide is found in a number of foods and pits of fruit, and they're found as cyanogenic glycosides, and that is metabolized to cyanide in our bodies. And so this cyanide has also been used as a chemical warfare agent throughout history, even as late as World War II. And what cyanide does is it irreversibly binds to the iron in the heme A3 portion, inhibiting electron transfer and complex 4 as well. So a little bit different mechanism of action than carbon monoxide, but it's doing a similar thing. So guys, take a 10-minute break.
We can push through the last 3 slides.
Do you want to push through? Yeah. Okay, sorry, I should have asked. I just didn't want, I know you guys may not have wanted to hear my talk. All right, let's push through.
Yes, sir. All
right. So, in this scenario, you have two young children, a 4-year-old girl and her 1.5-year-old baby brother developed vomiting and coma 9 hours after ingesting boiled cassava. At a local hospital, both were intubated. The girl was transferred to the ICU and received sodium nitrate and sodium thiosulfate at 19 hours post-ingestion. She recovered the next day. The boy was transferred 4 hours later, showing only bitter almond breath. That is a common smell, chemical smell produced by cyanide, but only about 50% of the population have the genetics that's able to smell it, so not everyone will smell that bitter almond smell. So the boy also received supportive care. Their blood cyanide levels were 0.56 and 0.32 micrograms per milliliter for the female and male respectively. Normal levels are below 0.3 micrograms per milliliter. And the laboratory results revealed metabolic acidosis, of course, because of that lactic acid buildup. And it also confirmed cyanide poisoning. So the main treatments for cyanide poisoning is hydroxycobalamin. You guys remember we talked about hydroxycobalamin used for another treatment in block 1, another poison. It's okay. It's arsenic. Arsenic. It's also used for arsenic poisoning. And then you would give sodium nitrate and sodium thiosulfate. Those are the gold standard treatment. So hydroxycobalamin usually for EMS persons, and sodium nitrate, sodium thiosulfate in the hospital probably, because those are the mainstay treatments. And so you don't need to know the dosing amounts, just know that those are the agents used to treat cyanide poisoning. And so again, cyanide irreversibly binds to iron in the heme A3 site, inhibiting electron transfer in complex form, decreasing ATP synthesis, and increasing the anaerobic pathway, which will cause lactic acid buildup and metabolic acidosis. Any questions? Yes.
Is it sodium nitrite or are those two the components of cyanide?
Say again?
Are the nitrite and sodium thiosulfate the components of cyanide?
They might be. I'm not sure. They might be. You mean like in those for EMS or paramedics? Yeah, it might be. I was under the impression that it was mainly the hydroxycobalamin, but it might include those as well. Any other questions? All right, you guys enjoy your weekend. Thank you.